Agatha Mamaril from BSN 2C, and I am here to demonstrate procedure for umbilical catheterization. For the assessment, a timeout should be performed with particular attention to assure that the correct patient is identified and to assess for any contraindications for the procedure. The procedure should take place inside a radiant warmer to avoid environmental exposure to the infant. For the planning, equipment as listed should be obtained and inspected. Appropriate lab work, if available, requires a review. Written consent is necessary from the parent or guardian of the neonate after a discussion of the risks, benefits, and alternatives of this procedure if not performing the procedure emergently. Then flush the catheter with heparinized saline to ensure that there is no air present in the catheter and to prevent clotting. Attach a 3-way stopcock to the catheter. For the equipment, radiant warmer, sterile gown, sterile gloves, cap and mask, sterile drapes, bactericidal solution, umbilical tape, scissors, scalpel, iris forceps, non-tooth forceps, umbilical vein catheter, 3-way stopcock, IV tubing, needle driver, 3-0 silk suture, sterile saline flush, sterile catheter sizes for preterm, less than 1,500 grams is catheter size 3.5 French. For term infants, catheter size are 5 French. For the implementation, put a sterile attire. The umbilical stump should undergo preparation with a bactericidal solution and a loop of umbilical tape placed at the junction of the skin and umbilical stump. Drape the procedural field with sterile drapes. Grasp the umbilical stump with non-tooth forceps and apply upward traction to straighten the umbilical stump. Take a scalpel and make a transverse cut completely through the umbilical stump 1 to 2 cm from the skin to expose the non-dried umbilical cord to aid in anatomical identification and cannulation of umbilical vein. Now, identify the 2 umbilical arteries by their thicker walls and the umbilical vein by its position at 12 o'clock and its larger thin-walled appearance. Umbilical tape may be tightened to control bleeding if present. Gently use the iris forceps to cannulate and dilate the umbilical vein and to clear any thrombus present in the umbilical vein. Now grasp the umbilical vein catheter with the iris forceps and gently introduce the catheter into the umbilical vein. If the clinician meets resistance, loosen the umbilical tape and attempt to advance the catheter again with gentle pressure. If the significant resistance is still present after loosening the umbilical tape, abandon the procedure and seek an alternative method of intravenous access. If the line placement is for emergency access, advance the catheter 1 to 2 cm past the point of initial blood return in the catheter, which is usually 4 to 5 cm in full term. If the line placement is for long-term access, the line should be advanced into the inferior vena cava just beneath the right atrium, which is usually 10 to 12 cm in full-term neonate. Secure the catheter using a suture to the cord. After suturing the catheter in place, use tape to create a tape bridge between the abdomen and the catheter for extra protection against displacement. Place a transparent dressing over the umbilical stump and umbilical venous catheter.